Hi, welcome to Health Talk with Dr. Akram. I am Akram. In this program, we'll be talking about all kinds of different health issues with different experts in the field. Today, we will be talking about anesthesia. So sit back, relax, and enjoy your time with us. On Thursday, April 7, 1853, Queen Victoria gave birth to Prince Leopold, her eighth child, after inhaling chloroform for 53 minutes from a handkerchief. So ended a long battle between the Queen and her doctors on the risks of pain relief and childbirth. Anesthesia means without sensation from Greek language. It's a state of controlled temporary loss of sensation or awareness that is induced for medical purposes. It may include some or all of analgesia, pain relief, paralysis, muscle relaxation, amnesia, loss of memory, and unconsciousness. Anesthesia enables the painless performance of medical procedures that would otherwise cause severe or intolerable pain to an unanesthetized patient or would otherwise be technically unfeasible. Attempts at producing a state of general anesthesia can be traced throughout recorded history found in the writings of the ancient Sumerians, Babylonians, Assyrians, Egyptians, Indians, and Chinese. During the Middle Ages, which correspond roughly to what is sometimes referred to as the Islamic Golden Age, scientists and other scholars made significant advances in science and medicine in the Muslim world and Eastern world. The Sumerians are said to have cultivated and harvested the opium poppy, Lower Mesopotamia, as early as 3400 BC. The most ancient testimony concerning the opium poppy found to date was inscribed in a cuneiform script on a small white clay tablet at the end of the 3rd millennium before Christ. Bianchi, 300 before Christ, was a legendary Chinese internist and surgeon who reportedly used general anesthesia for surgical procedures. It is reported in the book of Master Han Fei, 250 before Christ. Bianchi gave two men named Lu and Chao a toxic drink which rendered them unconscious for 3 days, during which time he performed a gastrostomy upon them. Arabic and Persian physicians may have been among the first to utilize oral as well as inhaled anesthetics. Ferdowsi, 940-1020, was a Persian poet who lived in the Abbasid Caliphate. In Shahnameh, his national epic poem, Ferdowsi described a cesarean section performed in Rudaba, where a special wine prepared by Zoroastrian priest was used as an anesthetic for this operation. In 1000, Abu al-Qasim al-Zahrawi, an Arabic physician described as the father of surgery who lived in Al-Andalus, published 30 volumes Kitab al-Tafsir, the first illustrated work in surgery. In this book, he wrote about the use of general anesthesia for surgery. Even though anesthesia has been around for few centuries, losing control, being unconscious, and fearing the unknown put all of us in anguish. Anesthetic practices evolved and advanced with advancing technology to make it precise and safer. The modern techniques render a better choice to the requirement of the patient and to the required operative procedure. Let's welcome our special guest in our show to clarify all these issues. Let's welcome Dr. Prasanna Tilakaratna, who is a consultant anesthetist in Essex. And also please welcome Emily Magalhaes, who is an operation department practitioner. Emily also works in Essex for NHS hospitals. Prasanna, it's nice to have you in the show.
Thank you for inviting me for this show.
Emily, how is your day? Thank you for being here.
Yeah, thank you for having us here.
Guys, it's nice. A subject, anesthesia, we talk about a lot of times, but not many people understand what it is. It's a mystery, isn't it?
Absolutely, yeah. I mean, To put it in a sort of a simple way, when you have surgery, as you said, you can't just go to a surgeon and get yourself operated there. You have to be able to tolerate surgery. And the role of the anesthetist, how I tell my patients, is quite simply, we put you to sleep so that you're not conscious of what's going on, and you will not feel any pain, and that allows the surgeon to do what they need to do. And of course, the other part of anesthesia is not only putting people to sleep, but waking you up at the end.
That's true.
Yes.
President, before go to the subject, let's talk about you. Who are you? What kind of job do you do?
I'm a consultant anesthetist. The word anesthetist itself is a very difficult thing to pronounce, so most people don't understand that word. But anesthetist is someone who delivers anesthesia, and I'm a consultant for quite a few years. I work in Broomfield Hospital in the city of Chelmsford in England.
And Emily, we would like to hear about you as well.
Yeah, I am working in operating theater. Mainly, I'm working with our anesthetist to help them put the patient to sleep, make them ready, anything that he needs. So I will be there for him to make the patient comfortable as well.
So you're an operation department practitioner. It's a hard word to say even for me, but let's explain a little bit of ODPs, operating department practitioner.
Mainly, our role is to prepare basically the anesthetic room, whatever the need of the anesthetist, needs of the patient, especially things that we prepare, the things that we anticipate, the things that our anesthetist be needed. We assess the patient, whatever they need as well, and make sure everything that we need during the induction of the anesthesia will be around, will be available, and quickly to
So do you
manage.
have a special training for this? Do you go to school for this?
Yes, I did my training in Chelmsford. Basically, I went to Cambridge under Anglia University to do my training. So I did it for almost 8 months. So I did it for 8 months, and we started doing this in a lecture, and then we did our actual training in the theater itself. So we were taught all the things that we need to learn in order to put the patient to sleep. All the things that we need, especially the checking of the machine, how we prepare the machine, how we prepare the patient, how we prepare the things that the anesthetist will be needed during the induction of anesthesia.
That's excellent. And you guys got a lot of technical knowledge, isn't it? Like, about the machines and what's going around. You know the instruments and things like that. Okay, let's go to Prasanna. Let's talk a little bit about role of anesthetist in a hospital.
Yes, so the role of an anesthetist, as we mentioned before, is quite. So a given hospital, like my own hospital, has like 25 operating theaters, and each one has some different type of operations. So our role is really to be able to allow patients to be put into a condition where they can tolerate surgeries. And as we said, it generally involves making you unconscious for the procedure. But a lot of anesthesia is not just straight away you come and see the patient and put to sleep. It involves very different stages. So, for example, we will talk through a journey how a patient will go through. But first, when you first see the patient, you try to make a plan about the anesthetic, and we have to, so every patient is different. Patients can be, as I tell my own students, patients can be from any age. Sometimes we operate, not in my hospital now, but in some other hospitals, say 1 week old babies can be operated, and we quite often see patients over 100 years old.
That's quite common nowadays. Yeah,
as well. So patients can be any age. It could be different surgeries. It can be the nose, ear, nose, throat. It could be the abdomen. It could be face or anything. And of course, patients have other diseases as well. So we had to put all these factors into thing, and we have to plan the anesthetic, and then we have to do the anesthetic, and I'm sure we will talk about that.
We'll talk about more in detail. Yeah. Let's explain a little bit of the role of anesthetists in the hospital. Like, do you guys work in a different departments, like intensive care unit?
So anesthetists, people associate us mostly with providing the conditions for surgery, as we said, but that is not our only role. We provide, for example, in the place of childbirth, Women can request epidurals, that is pain relief during childbirth, that anesthetists provide, and of course cesarean sections is provided by anesthetist. Then we quite often run intensive care units as well. And another area which people don't realize is pain relief. Some people suffer from very severe pain that lasts for many, many years. Quite often anesthetists do that kind of role as well. So we are in many, many different roles. Yes.
That's true, isn't it? Not many people realize that anesthetists work in different parts of the hospital and different departments, isn't it? They just relate anesthetists to operating department, and they just put this patient to sleep just before their surgery. Of course, as you said, they work in the maternity, they work in the intensive care unit, in interventions, isn't it? In the radiology departments.
And we have to bear in mind that there are so many different types of surgery.
Exactly.
So, from top to bottom, there are different
neurosurgery, cardiac
Absolutely.
surgery.
So,
what is the toughest anesthetic procedure for an anesthetist? What do you think, in your opinion?
I would say the biggest challenge that we have is most of us, the population is an aging population, and that means that people have more diseases, people are living longer. So those are challenges, but we are very well able to deal with those challenges. But modern population can be quite elderly, and as I said to you, it's not uncommon to see patients in their 80s, 90s, or even over 100. And those are of course challenging, but that's what we like, that's what we train for.
Exactly, yeah. So cardiac surgeries and this liver transplant, they can be quite...
Yes, I mean, yes, there are so many things, but we have to bear in mind that for a given patient, even if your operation is very small, we know that that is very, very important for you. So big or small really doesn't matter. We give the maximum. We want you to be a happy patient and a safe patient.
That's good. This is a live program, so call us on 0203 515 5788 if you have any questions or suggestions, or write to us healthtalk@intv.co.uk. And you can also follow us on Twitter and Facebook, Iron Health Talk with Dr. Akram, and our special dedicated YouTube channel, Health Talk with Dr. Akram. And of course, you can watch us on Facebook Live, intv.co.uk. Okay, Emily, let's talk about you. What is your role in anesthetics?
My role in
You have
anesthetic.
elaborated a little bit. Let's go ahead
Yes.
and explain a bit more on the day of the surgery.
On the day of the surgery, from the one I said earlier, preparing the anesthetic machine, preparing all the materials that our anesthetist needed. So we also make sure that the patient is comfortable during the induction of the patient. So we always consider the safety of the patient, and then make sure everything that possible, the things that we need should be on reach at all times. And we don't waste any time, because it's a crucial time, especially during induction, that we act quickly, and with the communication with the anesthetist, we can easily implement the safety of the patient all the time.
Thank you very much. Prasanna, let's say if I come for an operation, what do I expect on the day?
I think so. We will go through, if I may suggest that we go through a journey, a typical journey. So say, for example, I know you're a fit, healthy man, but say you needed a knee operation. Step one really is for the patient and the anesthetist to get to know each other. I think that is the very key thing, because it is the only time in your life probably that you give your whole life to somebody else to look after. So it's very important that the patient has our confidence that we will look after you well. So that's my starting point. The second thing is we do have to understand the patient's diseases that are there, because we have to, I sort of tell my students, anesthesia is a little bit like cooking. The ingredients are common to many, many anesthetics, but we have to adjust the ingredients according to the patient. And so, for example, and I think as a patient, a good thing is to be prepared to tell the doctor or the anesthetist about the diseases. So for example, what diseases you have. Do you have cardiac problems or breathing problems? What medicines you take? How is the control of those diseases? So say, for example, you're an asthmatic. Is the asthma well controlled or is it poorly controlled? Is your diabetes well controlled, poorly controlled? All that kind of things, the anesthetist will ask you those questions, and I would try to get to know so that I can then plan. And the second step in this is, of course, once I make a plan, is to make sure that you understand the plan. And I have to stress that nowadays, in the old days, the doctor was the god and the patient was down there. Today, everything is very different. The patient is the king. And our role is to make sure that the patient understands and the patient agrees with the plan. If you don't agree, I don't do what you don't agree with. And that's the key thing.
So they can request a kind of anesthetic they want.
I think we have to be a bit careful about the request part of it. More like I should give you the menu, the options that are fit, that are suitable for you, and then I tell you to choose which items that you like. I think that's the way I would look at it.
That's a really good way of putting forward. Let's talk, Emily. If someone comes to your anesthetic room a bit stressed, and what do you guys do for that kind of people?
I'll make sure that they're comfortable, and then reassurance is always the key, that to make them calm, especially children who are really scared, and new faces for them. It's really a stranger, new environment. So we really make them reassure that during those times that they were there, we will be there to look after them.
That's a good point. And for people who doesn't like needles, are there any?
So it's quite interesting that I've been an anesthetist now for many years, actually decades. I'm ashamed to say. I'm not that young. Now, it may surprise you to hear that I don't like needles myself.
While we're talking, Prasanna, I'm going to get a video ready. We're going to play that video all about ventilation.
Yes.
Keep talking about
I don't like needles myself because I'm also human. So what we generally do is, we always need to put a needle in, but we always start with a very tiny needle first. If we need to put bigger needles into you, we generally first use the tiny needle to make you sleep, and then we put the bigger needle. And in children, quite often children don't like needles at all. There's some special creams that can be numbing the skin, or sometimes we can give some gases for the child to breathe and put. But it's always good, again, when we meet the patient in the morning of surgery, that you discuss this aspect and we can work around it.
So it's a good point that we elaborate these things and our viewers can understand. There's always a hope, isn't it? There's always a discussion, and you could choose what is right for you, isn't it?
Absolutely.
Yeah. Let's play this video. This is kindly provided by Genius Engineering. It's an amazing video which we prepared for you. This is all about how ventilators work and how it provides oxygen to your lungs while you are sleeping, especially when you can't breathe. Okay, let's watch the video.
Around 19% of people diagnosed with coronavirus are in severe or critical conditions. Severe cases may lead to pneumonia or respiratory failure, which might leave the patient requiring assisted breathing through a ventilator. This video provides a quick overview of how mechanical ventilators work to ensure vital organs and tissues receive sufficient oxygen to function normally. How does the respiratory system work? The autonomic nervous system triggers respiration by sending a signal to the diaphragm and intercostal muscles between the ribs. This allows for the lungs to contract and expand, resulting in a lower internal pressure. The air moves in through the nose and mouth towards the trachea into the bronchi, travelling to the left and right lung. The bronchi branches out to smaller bronchioles with small alveoli attached at the end that inflates due to the air breathed in. The alveoli, a small air sac in the lungs, are wrapped in carbon dioxide-rich capillaries. The inhaled oxygen molecules interchange with the carbon dioxide molecules through the process of diffusion. Another signal is then sent to the diaphragm and intercostal muscles to relax, leading to a higher pressure in the lungs, which forces carbon dioxide-rich air out of the lungs. This results in a smaller volume and higher pressure. Severe cases of COVID-19 with symptoms of pneumonia or respiratory failure causes the alveoli to fill with fluid, which makes it extremely difficult to breathe, thus requiring the aid of mechanical ventilation. How mechanical ventilators work. Mechanical ventilation involves using a ventilator to assist or replace the patient's breathing. This may involve a machine called a ventilator, bag valve mask or BVM, which is compressed by a medical professional. The most common mechanical ventilators used apply positive pressure to the opening of the airway, and air is forced into the lungs. The ventilator is a closed circuit that is attached to an endotracheal tube in the patient's airway. On inhalation, the oxygen-rich air moves from the ventilator to a heat-moisture exchanger, where the air is heated and humidified to simulate natural air. Air is then forced into the lungs, following the same route as that of normal breathing. On exhalation, carbon dioxide-rich air will be exhaled passively. With COVID-19 patients, it is important that pressure is always present on the lungs after exhaling to keep the alveoli open and assist with oxygenation to reduce breathing effort. Positive end expiratory pressure, or PEEP, is used in ventilators to keep this constant positive pressure. Mechanical ventilators constantly monitor the pressure, volume and flow of air. Medical professionals use the monitored variables to choose the best ventilator mode for the particular patient. Invasive mechanical ventilation involves an instrument placed through the mouth into the trachea, such as an endotracheal tube, whereas facial masks and nasal prongs are commonly used for non-invasive ventilation. Two examples of ventilator side effects that coronavirus patients may experience include barotrauma, which is the rupturing of alveoli due to excessive pressure, and volutrauma. The alveoli is damaged due to excessive overinflation of an organ.
Thanks a lot, Genius Engineering. That's an amazing video. I think you elaborated really well about the ventilation. We are very grateful for your video. For anybody who want to watch this video, this is in YouTube. You can go to YouTube and look for Genius Engineering, and you'll find all about this, and there are a lot more videos from the same person. Anyway, Prasanna, this is amazing. Let's talk about this. How do you make sure I am safe during the
Yes, so safety is a very, very, very important aspect of anesthesia. We are completely safety driven, and quite simply the key word is monitoring, and that means basically to observe your body systems, how they are functioning, and are they functioning all right, and continuous monitoring. And for example, if you take each system in your body, we generally monitor them, especially so your heart with ECG, your lungs with the settings on the ventilator like you saw, and lots of things, and even the anesthetic gases that we use to keep you asleep, we are monitoring those levels. So everything, it's a continuous monitoring throughout the case. The anesthetist team pure role is to make sure that you are safe, and that's the bottom line, really.
That's a good answer, Prasanna. Actually, when I was like a junior anesthetist, I learned safety from you. I still remember.
Good, you have good memory. Yes, yes.
You taught me how to be safe, how to be vigilant, and this is like, you gaze through that, you scan through one end to the other and make sure the patient is safe.
Yes, so we really literally scan top to bottom each of every system. It's really, really because it is a seriously, it's important job, and we don't sort of make light of that.
Actually that's the same thing we do as a pilot as well. In the pilot training,
yes.
They always, because when you keep looking at the same place in the horizon, you keep missing a flight coming in front of you. So you have to always gaze around and come back to the same place.
Yes.
And thank you very much for teaching that. But anyway, today we are talking about anesthesia. This is a really important topic. we know about it, but not many people really understand in the depth of it and what you need to know about anesthetics. So, so far we have talked the basics of it, and we're going to discuss more about the problems and complications in the second half. So until then, we're going to go for a quick short break, and we'll see you afterwards. Thank you very much. Hi, welcome back on Health Talk with Dr. Akram. Today we're talking about anesthesia. This is a really important subject. If anyone joined so far, we have talked about the basics of anesthetics and what kind of anesthetics you can get and stuff. But we're going to talk more about anesthetics, so be with us. And let's talk, Prasanna. How do you know when to wake me up during the operation, after the operation?
Yeah. So a common question before even waking you up is how do you know that the patient is asleep, basically?
Oh, that's a good point.
Yes. So that's
how do you know
sort of many people are worried about it. I have to say, you know, there are of course complications in any specialty and all that, but being awake. Being unplanned and being awake is very, very rare, I have to say. Okay?
So during the operation, somebody being awake is very rare.
So I can say in my career, which is over 30 years or so, I haven't had a single patient say that they were awake during the operation. Okay? And how do we know this? Because we have very special monitoring devices that can, so when we, generally speaking, one way of giving anesthesia is using special gases.
Anesthetic gases.
Gases. So they go into your lungs and all that, and this machine tells us the concentration of that anesthetic agent in your body. And we know, taking your age and all those things into account, that this number is what keeps you asleep. And we also monitor your heart rate and all those things, because, for example, if you're getting light, as we say in our language, where the patient is getting less deep, then the heart rate will go up, for example. So we keep monitoring those things. We monitor the anesthetic agent, and a bit of experience put into the whole mix.
Since you said about gases, let's talk a little bit. Let's explain to our viewers the gases what we give. How do they make someone to sleep?
Yes, now that is probably needs another 2-3 programs to explain it in detail. But bottom line is that these anesthetic agents, so your brain is full of electrical connections, quite simply, and these anesthetic agents, they go and they sort of stop those connections, if I can say that, and therefore it stops certain thought processes, and it slows the brain down in a way, and that sort of makes you unconscious. You can sort of think of it like sleep, but it's a deeper plane of sleep, of course.
Plane of sleep.
Yes.
That's a really good explanation. So it just simply explained these gases go through your lung, they get absorbed into your bloodstream.
Yes.
Then they reach the brain somehow.
Yes.
And that's
exactly.
the place it works,
So the gases come through a special machine into like tubing into your lungs, into the blood, into the brain, and then these brain circuits are sort of quietened down and things. Now, the other part of your question was actually how do you wake someone up?
Exactly.
And very simply, it's the reverse process. We switch off the gases, and then the gases slowly come out of the brain, into your blood, into your lungs, and into the outside. So it's just a reverse process.
And this is a simple diffusion, isn't it?
Yeah. So when you say diffusion, things like to move from areas where they're strong into areas where they're weak. So basically, from your body, it comes out, and it's a question of timing. And as an anesthetist, we have experience about different surgeries. We know which surgeries are short, which ones are long. In my own hospital, some surgeries are literally 5 minutes, small little bit of pus or an abscess. They'll cut it, the operation is finished. We do some operations which might be one patient, 15-hour operation.
15 hours.
Yes. So we have experience about how short the operation, how long it is, and then we adjust these gases so that they are there when you need them to be there, and they come out when the operation is over.
Okay, you're going along with your question. To be an anesthetist, so you have to be a doctor first.
Yes, so
and you have a training, isn't it?
Yes, so a lot of misconception is there in the UK and many countries as well. Generally speaking, being an anesthetist, you are a fully trained doctor. A lot of people don't realize it. In the UK, to become a consultant anesthetist can take in the region of 15 years. Okay,
So 15 years of training.
Training from entering medical school to coming out as a consultant. So it is like any other doctor, but we are quite often in the background. So sometimes people don't realize it there. Some countries have different systems, but certainly in the UK and many countries, you are a fully qualified doctor and a qualified specialist as well. Okay. But I have to say, just a quick word, if I may, we like to think of ourselves as a theatre team. And there's no, this one is a consultant and someone else is a nurse and all. That is very old-fashioned way of looking at it. This is a whole teamwork. Emily does her role, I do my role, and we interact. And that makes it a safer system as well.
Exactly. So we work in a team, isn't it?
Absolutely.
You share the jobs.
Absolutely.
And everyone has a part in that.
Absolutely.
In that job.
Absolutely.
So, okay, Emily. After the operation, when the patient has been taken to the next level, it's called recovery.
Recovery, yes.
What happens there?
So when the patient is in recovery, so a nurse will be looking after this patient. They will be monitored, still on their observation. The blood pressure has been monitored, their breathing pattern has been monitored until this patient is fully awake. They test the level of consciousness.
So initially when they come, they're half awake.
Half awake most of the time, yes, until they're fully awake. So then recovery nurse will be there to look after the patient, make sure that they're free from any pain and very comfortable.
So they make sure that patient is safe and comfortable, pain-free.
Yes.
And once everything is clear, they can send them back to the ward. Next level. Oh, that's a good point. Yeah. Oh, this is. We talked about it. I think we said it's very unlikely someone will wake up during the operation, sit up and say, "Oh, I'm awake."
Yeah. Yes. Absolutely. Absolutely. Yes.
Yeah. This doesn't happen, is it? But awareness. People worry about it. There's a lot of YouTube clips, I think, if you go and check it, people claim that they've been aware of things, what's happened while the surgery was going on. How common is it? But again, there are lots of anesthesia as well, isn't it? There's kind of
I have to say,
amount of misinterpretation as well.
I have to say, it's very difficult to quote exact numbers and all that, but as I said to you, in my career of decades and decades, I haven't had a single patient who has said that they were awake during the operation. And there are things that we can do if someone gets, even...
There are two things here, isn't it? One is waking up, like open up and see things, and the other one is you've been ventilated with a machine or something, but your brain functions, your brain process things around.
Yes, I think, we have to be, so the word awareness basically is used to say that, it's everybody's nightmare, isn't it? Everybody's fear that you are awake and they're doing this big operation on you. Now, that is exceedingly rare, I have to say. And I can only say, I don't know of any in my own hospital. Even I haven't, heard about it happening. So, and we do lots of operations. Our job, nothing is zero risk, but if you go back to what I told before, how we monitor the anesthetic gases and the quantities there, we're monitoring your body systems, and putting all that makes being aware or being awake during an operation extremely, extremely rare event. There are some specialized monitors where we can monitor the brain activity as well. We use them in some circumstances as well to judge if someone is asleep.
But of course, I think if you have given a patient a regional anesthesia, like you anesthetize a limb, for example, for an arm or for a leg or something.
Yes, so I think we're entering a different. So when we talk about, so far we've talked about putting people to
general anesthesia,
sleep for an operation, but that's not necessary. So there are areas, say, so my own hospital, we do a lot of hand operations. So people try to repair things, or they have a fight or whatever, they get big cuts in their hand, or sometimes even loss of fingers and so on. So we're able to actually anesthetize only the arm.
Only the arm.
So we have a special machine, like an ultrasound machine. We put it to the arm, we find the various nerves that supply the arm, and we give injections, and the arm becomes completely numb, and the surgeons can operate. And quite often patients are awake talking to us, and we play some music in the theater, and it's there. And some patients may get, if they're anxious, we can give them what's called sedation, which is making them a bit drowsy. Now, it's important that that is not the same as full asleep. By definition, when you say sedation, the anesthetist should be able to talk to the patient if necessary. Okay.
But you reduce the, you make them less anxious.
Yes. So as I said,
a bit comfortable.
When you see a patient before the surgery, we have a joint plan there. So this, if you're a very anxious person and all that, that may not be suitable for you.
Yeah.
So it's agreement with the patient, and then and I always tell my patients, if, for example, we are operating and you don't like it, I can even put the patient to sleep during the operation.
Yeah. For example, if my grandma is going for an operation, she's elderly at this age, and she's got lots of medical problems, and she's going for an operation in her hand. So this must be one of the good procedures.
Absolutely. So I would say, I don't have the exact figures with me, but in my hospital, the emergency list, which does hand operations, I would say 90%, on some days when I'm doing it, 100% we don't put to sleep. The whole day we operate on 10 or whatever patients, giving this injection, arm is numb, patients listening to music or talking to us about their life, and the surgeon is operating. And sometimes patients want to see the operation, and sometimes we actually lift the arm up and show the patient this is what has got damaged, and this is what we are going to repair. And patients go home happy.
That's a good point. And of course, it's the same thing you do for cesarean sections.
So cesarean sections, almost all cesarean sections, we certainly in the United Kingdom, we don't put to sleep the patient. The patient's awake, husband is also there, and the mother can see the baby very quickly, and it helps the bonding. I think, Emily, you would agree. The mother seeing the baby soon after birth is great.
That's a good point. So it's again, if somebody doesn't like to go to sleep for the operation, people are different. And some people are really afraid of going to sleep, so they can always choose when it's possible this kind of procedures.
Absolutely.
Especially if they're operating on a limb, upper limb or lower limb, you could
absolutely. So I used to anesthetize for a hip and knee surgeon. I would say almost 100% of my cases were done with an injection to the back, and if the lower half of the body is numb, upper half of the body chatting to me during the operation. And touch wood, I have not had a single patient in my whole career so far who's found it like, oh my God, what's happening? No, they're all relaxed.
It's all the preparation, isn't it?
Absolutely. It's a partnership of the anesthetist and the patient.
Yeah. What do you do for when you get small kids in the list? Do you separate the mother and child from the ward, or how does it work? How we do it
for the little child? So usually we bring the mother into
the mother
can come
to the operating theater as well.
Come to the anesthetic room until the child is settled, and then but before sometimes like halfway asleep this guy, then the mom will go. So but we make sure that the child is comfortable, that mom is there before the anesthetist put them to sleep.
That's great. Okay, we have a caller online. Hello. Walaikum assalam, sir. What's your name?
Rahman.
Rahman, where are you calling from?
Calling from Birmingham.
Birmingham. Oh, excellent. Thank you very much. Okay, please go ahead, sir, with your suggestion or question.
আমি এটা সবটাই না আছি আপনারা যে এটা যে প্রোগ্রামটা কথা এটা কোন বিষয়ের উপরে হেল্প
Sorry, are you talking in Bengali? Sorry. if you if you want to make any questions in Bengali, you could always talk to our team in the control room. You could make your questions with them and they will translate it for me. Unfortunately, we don't understand Bengali, but of course we'll come back to you with the answers, and we'll help you out with that. Thank you very much for your call anyway. Okay, cool. So we talk about the mothers can come to the operation.
Yes, definitely the mother can come with her daughter or the son in the anesthetic room. Before our anesthetists put them to sleep, they make sure that the child is settled.
Okay,
So-
that's good. Prasanna, there's always people worry about it. Okay, there's two groups there. Yeah, here we have a young fit group who come to the operation. They are generally safe. Then we have this elderly people with multiple problems, and they got a little bit of dementia as well. They got heart problems.
Yes.
They got lungs and they got diabetes. You just name it. They got everything.
Yeah.
And these people also want to hang around, live their normal life. They walk around. They
Yes.
fall and they break the hips and things like that. They come to the operation, and these guys, people always worry about death.
Yes.
Yes.
Yeah. So
Okay, while you're there, there's another caller
Yes.
there. Let me join the call as well, so we can all go
of
ahead.
course.
Hello.
Hello, brother. I'd like to know this doctor with the black jacket on. Is he a, doctor himself or?
Yes, he's an anesthetist. He's a doctor. Go ahead, sir. Do you have a question?
it's cut off.
It's cut off again, I think.
Okay,
Okay, that's
okay.
fine. So this is about
Yes.
people worry about.
Yeah. So basically, we're talking about risk, isn't it? What is the risk? I think what my approach with this kind of thing is to be honest with the patient, because as I said before, patients are the god in this whole thing. They are the king of the thing, and our duty is to tell the patient in a very honest way, here are the benefits of your surgery and things like that, and here are the risks.
Yeah.
And it's my duty to explain it in a way that the patient can understand it. And I'm very upfront with some of my surgeons. They do very high risk operations in 80, 90-year-old patients. And I'm very upfront with the patients. I say, look, this is what can happen. This is what can go wrong. This is what I will do to make. And generally when patients are told in this way, patients are also very practical. People know, they have understanding of, what is the meaning
Especially
of this.
when they have many
Yes.
medical conditions.
Exactly. I have to say that anesthesia and medicine has come a long way.
Yeah.
So even patients with quite serious diseases, we're able to manage them.
Yeah.
But sometimes patients tell you, doctor, please do some method which has no risk.
Yeah.
That is impossible for us to do. There's always some risk, but the risk is very, very small. I mean, there is risk of this studio lights falling on our head.
Exactly.
But you have to put the risk in the correct perspective.
Yeah.
Yes. And I'm very upfront with patients because I think it's very important to be honest. Now, sometimes patients may indicate to you that they don't want to know the risk. That is fine.
Yeah.
But I always tell, ask me whatever you want to ask.
So generally for fit people, the risks are low.
Extremely low,
Extremely
even
low.
in the high end
Yeah.
of risks. We have come a long way now.
That's right. Isn't it?
Yes.
So when you're operating on these major cancer operations and
Yes.
where their life expectancy is short and there is a lot of involvement, that's the time people, there is a possibility they can die.
Yes.
But you explain
No,
them.
so it is, I think, not only anesthesia, but even the surgery is very important to...
Prasanna, let me
Yes.
join this caller. Hello?
Yes.
Hello, you are on there. I think the caller has dropped again, so
Yes,
let's go
a
ahead.
bit of
Thank
connection
you.
problems. Yes. So this whole thing about surgery, anesthesia, nobody just goes for surgery for fun or anesthesia for fun. You always want to know what is the benefit of that surgery and what are the risks. And I think as medical professionals, that's our duty to make it clear to you. At the end of the day, the patient has to make a choice.
And of course, when you do major operations,
Yes.
you send them to special places to make sure that they are sleep for another longer time, so especially intensive care unit.
Yeah, so I think as you were saying as well, in the recovery, the important thing is the patient has a journey. You come into a ward, then you go into the anesthesia room, you put to sleep there, you go on the operating table, and then after the operation, there's a pathway. So you go to the recovery area where you're sort of drowsy and the nurses are looking after your life signs to make sure that you recover nicely. But your journey beyond that depends on a lot of things, including how complicated the operation was and how that. And if you are someone who your body needs more support to recover, then we have things called intensive care units or high dependency unit, which is another way of saying less intensive care, or you can go to a ward. So that all depends on the patient. So for example, there are young patients who come for a small operation on the hand. Patient goes home in 2 hours. On the other hand, you can have a 10-hour operation and that patient may need a bit longer to recover. So we'll have a special recovery for longer patients. Or you can have patients with very severe lung disease or something who need even longer time to recover. Then we put into the intensive care unit and then they slowly wake the patient up. But in general, you don't want to keep a patient unnecessarily asleep. So as your body starts to recover, you wake the patient more and more up.
Quickly.
And that's the same principle in intensive care. Nobody keeps someone in intensive care unit for fun. As soon as you start getting better, they start doing all these tubes and things start coming out and you go to the ward and then home.
At home. Emily, what's the difficult part of your job?
Difficult part. Oh.
Yeah, she's caught you off guard.
Caught me.
I wanted to catch you with one question at least.
I would say when really emergency, that that you really need a hand to help you. But we always make sure that we are ready in anything comes along the way in front of us. I think that's the most crucial part that I encountered, during that time, that it's really emergency, that you need more hands to help you.
So that's the time your heart rate goes up and the patient heart rate comes down.
What do you call it? Adrenaline suddenly kick out. Yeah, that's it.
I have to stress to people that when emergencies happen, we are trained to deal with those emergencies.
Exactly.
So yes, of course, we get stressed up, but it's under control.
Yeah.
That is the whole part of our training, is the keeping under control. And we will sweat sometimes, we will have a bead of sweat forming on us, but it's keeping calm, being thing, and we practice as a team all the time to deal with these kind of things.
Deal with these things. President, we got only probably 1 or 2 minutes left. Let's talk quickly. If an elderly patient comes to the operation, there is a possibility that they might live or die.
Okay.
Can they have a choice? What they expect afterwards?
Absolutely. I mean, this is a topic in itself, but one must have a plan about one's life. No one lives forever. That includes all three of us here. Things, and one has to have a realistic option, and that should be discussed with the medical team as well, and the necessary paperwork has to be there as to if things were to go wrong, how much do you want the medical team to act on it? Support, because medicine is so technologically advanced that we can sometimes keep people going
forever
without a quality of life. But that is an important thing to discuss. To be honest, that's something we all must discuss, and that our families must know as well what our wishes are. Because doctors and nurses and all will generally ask the family as well, but what was his opinion about these things? Okay. Yeah.
Oh, thank you very much. Okay, both of you, in the end, for our viewers there, is anesthesia safe?
You could answer that first.
Emily, here we go.
On my point of view, yes, it's safe as long the people working on the team is there to support each other, understand what's going on, good communication. So, and then the patient is aware beforehand what will be happening. He's aware, he knows what's going on. what will be going on, and having this communication from time to time will be really, for me, it's safe.
Yeah, definitely. The word safety is when I start my day at about 7:30 to finishing around 6:37. Safety is paramount. That we are breathing safety all the time.
All the time.
There's no question about it. Yeah.
Thank you very much for you, for both of you, Emily and Prasanna. It's an amazing program, and within short time, we have explained everything they need to know about anesthetic. This is a short program, but we have done everything they need to know. But anyway, today we talked about anesthesia. This is a really important subject, and which you might know, but it's always better to know a little bit more, so you don't have to worry much about it. But anyway, if you have missed it, you can always follow us on our Health Talk with Dr. Akram YouTube channel. These programs will be uploaded probably within 1 or 2 days, and you can always look there and leave a comment for us. And if you have if you haven't subscribed so far, please do subscribe so you can get all the videos there. And by the way, next week we're going to talk about fracture neck of femur, why elderly people fall and break things. We're going to discuss more about what happens, why they fall, and a little bit about the surgery. But for today, thank you for staying with us on ION's Health Talk with Dr. Akram. If you have any further questions, please email us healthtalk@iontv.co.uk or message us on our dedicated YouTube channel, or Facebook, Twitter, or Instagram. We will respond as soon as we can. But for now, goodbye and keep yourself safe. Thank you very much.